All right, welcome back. In the last two videos, we focused specifically on the importance of critical evaluation of machine learning model performances. In this video, we'll focus on understanding the black box of machine learning models and dimensionality reduction. Machine learning models are often called the black box model just because it's very difficult for uh, the users to understand how the machine learning got to its conclusion. This makes it a little bit more resistant to users to use those machine learning models. If they understand a little bit more of how the model got there, it'll make it more comfortable for user to use. So by checking if machine learning reasoning is in line with the clinician's intuition is important. However, when we use 48 variables, that's a little too much for the clinicians to consider and to order for every patient. So there we considered dimensionality reduction. How do we do this? Well, first, you rank all the variables, all the 48 variables in order of importance. Then take the top 10 variables and then use those top 10 only to rerun and train the machine learning models. And then you compare it between when you used all 48 variables to make a machine learning model versus when you used only 10. And then if you are successful in making a good performing model with just 10 variables, you could use that uh, model to build a calculator, a predictor. So there are many ways to look inside the black box, and one way is to use a heat map. Here, the AutoML generated many machine learning models, and those are on the x-axis, and on the y-axis is all the variables that we use, the 48 variables. And you can see on up here, there are more variables that are red or yellow, and they were considered more important for each model. But model variables down here or around here that are more dark blue are variables that wasn't as quite important for a lot of these models. Another way to look at it is the standardized coefficient magnitude. Um, and age was the most important, followed by systolic blood pressure. And orange means that higher age was higher risk for death. And blue meaning lower blood pressure was a higher risk for death. And another common way to evaluate the black box is the SHAP model. Each dot is a patient, and uh, red means higher value for that specific value. So for systolic blood pressure, uh, red means higher systolic blood pressure, and they have lower mortality rate. So everything on this side of the dotted line, is more likely to survive, and this side more likely to die. So if we look at age, red means higher value, so older people were more likely to die. And this is just comparing between two different kind of model, the GBM model versus the XGBoost model. And after all these analysis and then talking with the clinician, we found that these 10 top 10 variables seems to be most predictive of the patient's mortality. So now we took these 10 variables and rerun the experiment, retrain the AutoML. So this is the output. The stocked ensemble model did the best again with area under the precision recall curve of 0.791 and ROC of 0.90. And here is the precision recall curve. And we named it model 10 because we were using only 10 parameters here. And then we remade the confusion matrix using model 10. And here are the outputs: sensitivity, specificity, positive predictive value, and negative predictive value. And these values were uh, generated based on optimizing the threshold by maximizing the F2 score. And that is where this dot is telling us. This is where F2 was maximized. And if you want to learn more about the F2 score itself, please look at the previous video. And here is the result comparison between model 48 and model 10. On the left, model 48, we could see that the area under the precision recall was 0.807 versus in model 10, 0.791. It dropped a little bit, but overall the performance was preserved. And here, the blue line is model 48, the red line is model 10. And you can see visually that there is a little bit of a drop in model 10, but overall the performance was maintained. And then maximizing the F2, we got these confusion matrix and then calculated the sensitivity specificity. And these are side-by-side comparison. And you can see that it really it was really able to maintain its performance with Model 10. Now with that Model 10, we made a calculator with the 10 variables. So the user can now input the 10 variables and then click submit here, and then you'll get output here saying, in this case, 97% survival. However, let's say we change the numbers and then we click submit. And in this case, in this patient's case, the chance of survival drops to 62%. So this calculator is available online, freely available, and you could try inputting different kinds of value and see what kind of output you get. And the data and the code is all in this GitHub repository. And some limitations of our work and future work. Some limitations, our cohort was limited to patients with severe conditions that require them to be admitted to the hospital, and therefore our findings may not be generalizable to all COVID-infected patients. And temporal features were not considered in our analysis, as in when is the patient more likely to die, first week or second week? Perhaps if they survive till second week, they are less likely to die. So those kind of temporal features were not taken into consideration. And it is still unclear what medical action to take based on the prediction. So if it's 60%, is that the time when you take the patient to ICU or not? When do you give the ventilator? These kind of clinical correlation is harder to answer. For future work, we hope that we could use these kind of models for other kind of disease, not just for COVID. And in addition, perhaps link it to electronic medical record system, EMR, with Smart on Fire. That way we could take all the parameters from EMR and do the calculation and immediately give the output to the user. So in conclusion, from this paper, and I hope that you get out of this video, is that first, check if the metric used to evaluate model are appropriate, as in it's not necessarily always right to use ROC. Sometimes PRC might be more appropriate. And F beta score, you have to tweak around with the beta itself. F1 score is commonly used, but that might not be the case for your specific study. And understanding the black box model and comparing it with clinical intuition is important, and considering dimensionality reduction to simplify the problem might be helpful for you in your research. So that is the end of this video and this paper. So hopefully that was helpful, and let me know what you thought and how you might apply this in your own study. And I'll see you in the next video. Thank you for listening.